Okay, this is the nervous system part 2. This will be a shorter video just over motor and sensory pathways, and we'll just keep plugging along with the nervous system videos. Okay, of course this is a messy slide. So we're going to focus here on sensory pathways, a really basic sensory pathway, not talking about special senses, which are vision, gustatory pathways, olfactory pathways. We're not going to talk about vestibular stuff, at least in regards to what we're talking about right now. Talking about motor, we'll touch on that. So a basic sensory pathway, so you see an awful picture that I drew. I have to fess up and say I drew it. This is a hand of some kind. This is a flame. Ouch, right? And that hurts, right? So that's potential painful stimulus, right? But if we come up here to somatosensation right here, so there's different kinds of stimuli we can sense or feel that are considered somatosensory. There's pressure, there's vibration, there's temperature, there's stretch, and there's also pain. So we have all kinds of sensory receptors. We have mechanoreceptors, we have thermoreceptors, we have nociceptors, which right here, nociceptors are the fancy ones for pain reception. And then these sensory receptors, especially in the skin, have all kinds of names, Merkel discs. And then there's a series of corpuscles called Pacinian corpuscles, Meissner's corpuscles, Ruffini's corpuscles. They're all a little different, but you don't have to know those for testing purposes. And then these right here, the bare wires or the free nerve endings, those contain your thermoreceptors and your nociceptors. But also somatosensation comes from other places too. So it could be deeper pain in the tendon, in the muscle, in the bone. It's not just the skin. Okay, so it's like you have a somatic motor system, you have a somatosensory system. Okay, and then periphery, that's how we're sensing things. And then these are going to be carried back through neurons, okay, to the somatosensory cortex. So somatosensation goes to the somatosensory cortex. That makes sense. So it's an example just showing the skin here. So these variety of sensory receptors. So the first neuron is attached to these sensory receptors. They get stimulated by various stimuli, whether it's temperature, pain, stretch, pressure, whatever. It goes through this we call a first order neuron, the first neuron, which then synapses in the spinal cord, right? Depending on where it's at. And we haven't gone over the spinal cord lecture yet, so we'll get there. And that synapse, it synapses with a second order neuron. The second order neuron ascends the spinal cord on the ipsilateral side. It's going to decussate, so this fancy word here, so decussation. So decussation means the pathway is going to cross over from one side to the other side, okay? And that's why if we have a stroke in the right hemisphere of the brain, you could have muscle weakness on the left. Or if you have a stroke on the right side of the brain, you could have sensory disturbances on the left, okay? And if left to the right, vice versa. So this decussation or crossing over, so when the brainstem, this crosses over to the other side, right, the contralateral side, and it's going to synapse right here in, of course, the thalamus. Remember, the thalamus is the sensory relay center for the brain, right? So all sensory information except for olfaction is going to synapse in the thalamus, and the thalamus will send it where it needs to go. And obviously this can be many places because some of these senses will go to obviously the somatosensory cortex, or if they're special senses, they'll go to whatever part of the cerebral cortex they're assigned to. But then they're also going to send signals to like the limbic system and even the cerebellum. So they can go multiple places, right? Either way, we're talking about a real basic pathway here. So the second order neuron, after decussating, synapses with the third order neuron, and then this is going to ascend to the somatosensory cortex, and this thing we call the homunculus. And I didn't draw a homunculus because it would probably look awful. But again, you can see, and we talked about this in class, so somatosensory cortex, it's the anterior portion of the parietal lobe. We can see here all those neurons, where all the neurons, right, are programmed into the brain. So genitals here, foot, leg, trunk, arm, and then hand, face, lips, and teeth, right? So obviously the face and the hands and all this stuff that gets about almost half like the neurons in the somatosensory cortex because there's a much higher density of sensory receptors, which makes sense. Your skin on your palm of your hand is more sensitive, and on your lips and your lips, and the skin on your back. Okay, so and then you can look this up, and there's the goofy drawings of the homunculus with the big face and the big mouth and the huge hands and the tiny body and all that stuff. But that's pretty much how a sensory pathway works, okay, in the most basic sense, okay? But the thalamus will send this wherever it needs to go. Here, the somatosensory cortex, okay? So again, we talked about different stimuli. So pain's a big one. Obviously, clinically, as nurses, that's your biggest thing you're dealing with is patients are in pain, all kinds of pain. There's other pain like visceral pain. So if there's ischemia to organs like the heart, right, that causes pain. If there's ischemia to a limb because of lack of blood flow, that causes pain. There's pain from appendicitis, cholecystitis, pancreatitis, and that's more pain from deeper organs, I guess, the visceral pain thing. So the leg's not really, that counts as what we're talking about. But so what are some painful stimuli? So cold and heat. So remember temperature, well, that's not necessarily a pain stimulus, but we get to these thresholds of cold and heat and things start becoming painful. You touch something really cold, it actually starts to hurt. You touch something really hot, it starts to hurt, okay? And it starts to hurt because it's getting to the point where it's going to start causing tissue damage. Also tissue deformation. If someone pinches you and starts yanking on your skin, pinches your skin and yanks on your skin like this, well, it starts hurting. Does it mean you're damaging tissue? No, not quite yet, but it can be uncomfortable. And then this can also culminate when if you expose the skin or tissues to too much cold or too much hot or too much tissue deformation, it's going to start causing tissue damage. Or, you could just say someone has a laceration, someone had surgery, which is controlled trauma, had incision through the skin, and they repaired a tendon or cut bone, right? That's going to be painful, but because of tissue damage. Or someone herniated a disc, someone fractured their radius in their own, all tissue damage, right? And what happens when we have tissue damage? We're not going to go over all the steps of inflammation, but it leads to this. It's crossed out here for a reason, but it leads to inflammation. In inflammation, you release all these different little cytokines and substances like prostaglandins and leukotrienes from the damaged tissue. And what some of these substances are going to do, they're going to bind to nociceptors and cause a painful stimulus. Okay, so anything that stimulates nociceptors, that's going to send the first order neuron, second order neuron, third order neuron to the somatosensory cortex, and it's going to be perceived as pain. Okay, so again, you can have pain without inflammation, and you can have pain without tissue damage. Also, you can have tissue damage and not have pain. We discussed that in class. So you can have ongoing tissue damage, doesn't mean you can have ongoing tissue damage and not necessarily have pain, right? But pain is there to tell you, hey, something's going wrong, okay? And inflammation, we'll learn this later, inflammation's there because inflammation's a good thing, right? We don't want to block a bunch of inflammation for too prolonged periods of time because we can actually slow healing. That's been shown in studies with fractures. When you give people NSAIDs for prolonged periods of time, it can actually slow bone healing. So inflammation is going to signal your body that something's wrong. Hey, bring in some white blood cells. Hey, clean all of this damaged tissue up and start stimulating growth factors for healing. Okay, so that's basically how pain works, right? And how you can block some of this pain. So here's the bottom line. If pain doesn't reach the somatosensory cortex or these pain signals, you're not going to be aware of it because we know the cerebral cortex is the conscious part of our brain. So where can we block pain? So NSAIDs and corticosteroids are anti-inflammatory. So corticosteroids, it's like prednisone, methylprednisolone, dexamethasone, hydrocortisone, right? You get a Medrol dose pack because you blow out your back. Okay, that's going to block inflammation. NSAIDs, so non-steroidal anti-inflammatory drugs. So these came later. These are non-steroidal, like corticosteroids are steroidal drugs. So this is your over-the-counter ibuprofen, naproxen, your prescription diclofenac, meloxicam, Toradol, all that stuff, okay? But if you reduce the amount of inflammation, right, you're not going to reduce nerve signaling, but if you reduce the amount of inflammation, you'll have less stimulation of the nociceptors and ideally less pain. But if the pain you're having is not due to inflammation, well, anti-inflammatories might not work so well. What else can you use? Well, look, I wrote two things here already. So opioids and cannabinoids. Here, Right up here, in purple, opioids and cannabinoids. So opioid drugs, they bind to something called the mu receptor, and they decrease signaling between the first and second order neuron here at the spinal cord, and between the second and third order neuron here in the thalamus. So that's how it decreases pain signaling to your brain. So if you shatter your femur, or have a tibial plateau fracture, or pilon fracture, or all the different names of fractures, whatever, and you take a milligram, or you receive a milligram of Dilaudid, next thing you know, you might have no pain at all if you're opioid naive, because you block these synapses. There will be hardly any signal getting your somatosensory cortex, and you are not aware of the pain. So they work great for acute pain, but like we've learned with other things in the nervous system, your nervous system will start adapting very quickly to this, okay? And over time, the same amount of pain medicine won't give you the same amount of pain relief, okay? Because it doesn't like you changing things like that. We've been over that with alcohol and other illicit drugs, and we'll talk about that even more later. So cannabinoids, this is in cannabis or marijuana. Well, marijuana contains all kinds of cannabinoids. THC is just the only cannabinoid that causes psychoactive effects. When you buy quote unquote CBD at the store, the gas station or whatever, or online or wherever you get it, it's just some kind of cannabinoid or series of cannabinoids from marijuana. So the other cannabinoids other than THC don't cause psychoactive effects, but they can decrease pain. They bind to CB1 receptors or cannabinoid 1 receptors here at the spinal cord and here at the thalamus, and they can reduce pain signaling to the somatosensory cortex. They bind to a different receptor, they work a little different, and a lot of the evidence shows they might not have as much resistance, right? People build a tolerance to opioids quickly and get addicted to them very quickly, but for cannabinoids, it seems like it's not necessarily the case, or not as much. Okay, that's a basic sensory pathway. Now, up here, just a side note about pain. So, pain, just for your own information, not testing purposes, but you're going to be nurses dealing with all these people in pain. So, pain, it's a biopsychosocial model. So, what a biopsychosocial model means is, of course, there's a biological aspect to pain. Okay, there's tissue injury, there's inflammation, whatever, tissue deformation. But there's also a psychological aspect of pain and a sociological aspect of pain. I explained this in class. So again, you're walking the parking lot to your car, you fall, you feel a crack in your ankle, it's your right foot, let's say, and you're on the ground looking up at the sky on your butt, and you start thinking, right? People say, oh, well, it hurts and this and that, but they start thinking, did I break my ankle? Did I just sprain it? How bad is it? Am I going to need surgery? Is my insurance going to pay for this? Is my right foot? Can I drive? Can I pick up my kid from daycare? Can I, go to work? If I need FMLA or short-term disability, is 60% of my pay going to be enough to pay my bills? Am I able to stay in school? And you can start freaking yourself out. So that's the psychological aspect of pain, and that can actually make things worse, make your pain worse, okay? On the flip side, if you have chronic pain, well, chronic pain, when it limits your activities, you can't do the things you used to do, this is going to have potentially very significant psychological effects on a person, right, on a human being. So there's the psychological effects of acute pain, and then the psychological effects that kind of wear you down with chronic pain. It can really, really wear you down. After weeks and months, and then even years, you have to think about these patients who've been in this chronic pain. They've had 5 back surgeries and have a spinal cord stimulator, and they can't do anything they used to do, and they're on disability, and depression can really be a big part of that as well. Now, last thing, sociological. So that's like your support system. That's how you deal with your coworkers, how you deal with family. Do you have support, with what you're going through? And that's the sociological aspect of pain. Okay, that's the sensory pathway. I think I said everything I need to say. All right, here's the motor pathway. So pay attention to everything on the right side of the screen. So movement is a lot more complicated than we kind of discussed before. So we could say, all right, well, a motor neuron goes and attaches to a muscle. The muscle fires because acetylcholine gets released, binds to acetylcholine receptors, sodium channels open, sodium rushes in, muscle gets excited, releases intracellular calcium, calcium binds to troponin. Troponin causes tropomyosin to move out of the way, so myosin can bind actin, it cleaves ATP, goes to the power stroke, pulls on actin, and it slides. It's that simple, right? From a nervous system standpoint, well, we'll talk about this in a little more detail. So we have a motor homunculus in the posterior aspect of the frontal lobe, just like we have the somatosensory homunculus in the anterior aspect of the parietal lobe. So the back of the frontal lobe, we have a motor homunculus. Similar setup, right? So similar setup here. So of course we're going to have more motor units for areas like our hand, right? They have all these small muscles and fine movements. There's going to be more motor units there than in large muscles like our back muscles just for pulling and our thigh muscles just for like running and jumping. So they're going to have a larger dedicated area here. So hand, face, and mouth. Okay, obviously some sensory areas aren't on there like the teeth and the genitals. So a lot less motor neurons for the foot, the leg, the trunk, and the arm. So very similar concept. But in this case, it's a starting in our brain. So we're sending a motor signal from the brain, okay, from one of these areas. So this is removing our, let's say this is our gastroc muscle or gastroc soleus, whatever. So a motor nerve fires from the cerebral cortex because we're conscious of this. We say, I want to plantar flex my ankle, flex my gastroc soleus muscle. So the first neuron is called the UMN. So UMN here is called the upper motor neuron. The upper motor neuron sends a signal. Okay, it doesn't pass the thalamus, but it enters the brainstem. Okay, it's going to decussate, so cross over. So you don't need to know this for the test, but about 75% of the nerve fibers usually cross over and the medulla, and the 25% cross over more inferior in the spinal cord. You don't need to know that. Just know it's going to cross over, but that can get more complex depending where you have an injury. But let's say you have a brain injury, so like a stroke or a TBI on this is like the right hemisphere of the brain. It's going to cause weakness on the left side of the body. That's what you need to know for now. Upper motor neuron descends the spinal cord and synapses here in the spinal cord with a LMN, the lower motor neuron, and that's the neuron that's going to extend to the muscle and then innervate a certain amount of muscle fibers. Remember, each skeletal muscle is going to have multiple motor units. So this nerve, though, contain many, many, many axons. Okay, we'll get over that later. Get over that, go over that. Okay, so there's an upper motor neuron, lower motor neuron. Oh, it's so simple. It's a little more complicated than that. So we'll talk about all the inputs that go into movement, and then we'll talk about the basal ganglia at the end. So the cerebellum. So we haven't talked about the cerebellum at all yet. So if you want to sum this up for testing purposes, the cerebellum coordinates all voluntary movement. So it coordinates your movement. And we saw videos of people with cerebellar ataxia where their cerebellum was damaged. Similar to if someone's really intoxicated on alcohol, what's going to happen when they go to walk, they're going to be stumbling. We saw they were falling to one side. They had a wide base of gait, and they couldn't do the tandem walking very well. So if you're in class, you saw that video. So it deals with proprioception as well. So the best definition of proprioception I have is knowing where your body is in space, or you could call it body awareness. So for an athlete, sometimes the more athletic someone is, the better body awareness they have. They know where their body is moving. So we use the basic example of someone closing their eyes and touching their nose, right? Doing a sobriety test, making sure their cerebellum works. We talked about how do I know my arm is moved in a certain position, my eyes closed, right? And we'll get to that, right? But that's body awareness or proprioception. And again, the most complex thing would be like someone during like wrestling or gymnastics, especially someone tumbling in gymnastics or flipping and twisting at the same time in the air, or someone's dunking a basketball, all kinds of things. It's like, how do they know where their body is, right? And how do they know to land on their feet? They're 6 feet in the air, twisting and flipping and all this stuff. Well, I'll explain as best I can right now. So all the inputs into the cerebellum, it has a lot. So one is visual, right? So seeing. So if your eyes are open, because here my eyes aren't open if I'm doing a sobriety test touching my nose, but if my eyes are open, which they usually are when I'm trying to move, right? You can see how far things are away from you. It's like your depth perception, right? It gives you an idea of how far something is away from your face and when you're moving and you can see it. So that's a big input into the cerebellum. Another input is somatosensation. So actually, touch. So touch. We can feel the surface of the ground on your feet, especially if you're barefoot, depending on what kind of shoes you have. If it's uneven, there's movement in the ground, you can actually feel that. Or you step on something, you can feel that. Okay. Or if you actually stuck your hand out and touched something when you're walking, or if you're doing some kind of athletic movement, if a hand or part of your body is touching your other part of your body, well, that's still somatosensory information that you're using. Okay, so if I do this, I know, okay, I've got my nose because I can feel it in my sensory receptors, my finger, and in my nose. So I did it, right? But another two more important things, very important things. So the vestibular portion. Okay, so vestibular information is coming from the inner ear. You have the utricle and the sacral, two structures for static equilibrium. There's actually little rocks called otoliths that sit in this gel membrane, and when you move your head, if I look down, these rocks just shift, bend these little hair cells in this gel, and it sends signals back to my cerebellum, my brain, saying, hey, the head's moved like this, and it's stuck, it's just staying in that position. That's static equilibrium. Dynamic equilibrium, if I'm turning my head like this and moving it, there's some other structure called the semicircular canals where fluid is sloshing around. So it's like when you get in a pool, I use the same example every time. I know it's boring. You get in a pool with your buddy or your friend, and you're doing circles in a little pool, and then you stop and the water keeps moving. That's why if you spin in circles and stop, you feel like you're still moving because that fluid is moving in the semicircular canals. Um, so that's for dynamic equilibrium. Okay, so that information's in your inner ear, which is in your temporal bone, and that's really important because what does that mean? All that equilibrium vestibular information, it's where your head is. So it's telling you where your head is in space. So the gymnast who's flipping and twisting at the same time, they know where their head is in space. If you know where your head is, it's like you're going to know kind of an idea of where the rest of your body is, like where your torso is, where your legs are, so on and so forth, if that makes sense. And then vertigo. So we'll talk about vertigo later. So if there's a problem with that, that's where you get vertigo. Some of those little otoliths leave the utricle and the sacral and get jammed in the semicircular canals, bend some of the hair cells, so you feel like you're turning and you're just like looking straight ahead, or it feels like it's pulling you to the ground. The last one, so proprioceptors. So actually proprioceptors. Those are little sensory receptors in the tendons, telling you the tension and the length of the tendons around the joints. So the joint capsules have sensory receptors saying how much stretches in the joints. If I know how flexed my elbow is with my eyes closed, well, there's receptors in the joint capsule telling me how much movement there is in my ligaments. And also the muscles. So there's little muscles, sensory receptors, and something called the muscle spindle telling you how much tension's in the muscles. So all the information comes to the cerebellum. And the cerebellum is going to have outputs to the premotor cortex and the motor cortex, so the motor homunculus, and saying, okay, this is how you need to fire and what pattern you need to fire all these muscles to have smooth movement, right? Because movements aren't just, oh, I'm bending my elbow at one joint. If you're walking, right, you're flexing and extending your hips, you're flexing and extending your knees, you're dorsiflexing and plantar flexing your ankles, you're dorsiflexing and plantar flexing your metatarsal phalangeal joints. There's movement between your tarsal bones. Muscles have to fire on your hips to maintain your pelvic posture when you're on one leg. So our gluteal muscles have to fire. So it's a lot more complex. That's just walking. So we have to fire all those muscles in a very smooth, proper pattern at the right times to have smooth, normal walking. So you can see if the cerebellum was messed up, we'd have a really hard problem balancing. Okay, so the motor cortex and the cerebellum can talk back and forth and straighten that out. So that's another whole big portion of movement. And the last portion, so refining movement right here, it's hard to see. I should write this bigger, basal ganglia. So it's a couple different areas of gray matter, subcortical gray matter, your putamen, globus pallidus, caudate nucleus, and substantia nigra. So these have a high density of dopaminergic neurons, and we talked about how dopamine deals with movement. What the heck is all that about? Well, this is what it's all about. So those areas actually send motor signals down the spinal cord. They have their own pathways, okay, with different names. Like there's tectospinal, rubrospinal, different ones. And it's a little more complex than this, but basically they're going to send descending motor signals that are going to just refine these motor signals from the motor cortex. They refine movement and make sure movements are nice and smooth. We see people with Parkinson's, they're losing dopaminergic neurons in those areas. They get very rigid. The mask-like face we call hypomania, shuffling gait, arms don't swing, and they have a resting tremor. They get tremors. We saw videos of that. We saw videos of people with Huntington's disease. They get real writhing movements. They can't control their voice because it goes up. The pitch goes up and down, up and down. So basically, if you have damage to those areas, you can get all kinds of weird movements like tremors and issues like that. Okay? So that's movement. The last thing I want to talk about is upper and lower motor neuron lesions. So down here, a UMN lesion and LMN lesion. So what's the difference? Just real basic. You learn more about this later. So if you have a lower motor neuron lesion, so if I damage this lower motor neuron, the nerves, the wires that go directly to the muscle, there's flaccid paralysis. Nothing's going on. It's dead. No firing, no anything. Okay, because that nerve that actually goes to the muscle's damaged. There's hyporeflexia. So if you get the little hammer and you whack people's knees, right? You get the patellar tendon, Achilles tendon, bicep tendon, tricep tendon. You check all those, right? Well, there's nothing there. Hyporeflexia. So depending how badly damaged the lower motor neuron is, it could be very minimal reflexes to none. Now, upper motor neuron lesions, so this is happening higher up in the spinal cord or in the brain, TBI, stroke, whatever, where the element could be like damage from surgery, could be gunshot, laceration, whatever. And some diseases as well. So upper motor neuron lesions, so you're getting potentially spastic paralysis. So the upper motor neuron's done, so there's no conscious control of the movement, so that would cause paralysis. But the lower motor neuron's still intact. This is the weird thing to understand. Sometimes when you take people who are paraplegic, take their legs, start moving them around, their knees are flexed, or extending their knee when it's flexed and try to manipulating their legs. Sometimes they'll get these involuntary spasms. They'll start spasming. You're like, what's going on? I thought they're paralyzed. Well, the lower motor neuron still has acetylcholine in it. If you jostle it around and move the muscle around, it could release some acetylcholine, which could stimulate the muscle, and the muscle might have spastic contraction. So we call this spastic paralysis. And then we check the reflexes, again, depending how bad the upper motor neuron lesion is. Doesn't mean someone's completely paralyzed. We saw videos of this. Well, the guy wasn't completely paralyzed, but he had some kind of upper motor neuron damage. He had hyperreflexia. He hit his patellar tendon, his foot, it kicked way out, right? So you'd see that. So all I want you to know for testing purposes is lower motor neuron lesion, flaccid paralysis, hyperreflexia, upper motor neuron lesions, spastic paralysis, hyperreflexia. So sorry, that was fast. You can always watch it on 0.75 speed. All right, that's part 2. Have fun.